We are closing it out very strong with a presentation by Carol Maltz called Caring for HIV-Positive Patients. This is a presentation with her research that she conducted under the mentorship of Dr. Adam McCormick. After Carol's presentation, we'll have time for question and answers and for her advisor to say a few things about working with her and to present her with the stole and cord in recognition of all of your work in the honors program. So without further ado, I'd like to turn things over to our next presenter.
All right, hello everyone. Welcome to my thesis study presentation. Thank you all for coming. And my project as a social work student is titled Caring for HIV-Positive Clients, Barriers to Long-Term Quality Care and Medication Adherence. And my research advisor is Dr. Adam McCormick, who's here with us today. And let's get right into it. Okay. So this is an overview of everything that we're going to be talking about today. So first I'm going to go over a little bit about what is HIV, and then what is HIV-specific medication adherence, and why it's important. And then for part two, I'm going to go into some research methods as well. So I'm going to be talking about my hypothesis, the methodology behind what I did, as well as the demographics of the people who were involved in the study. And then for part three, I'm going to go into results of the study that I performed. So we're going to talk about thematic analysis and conclusions, as well as implications and recommendations for further research. And then I'm going to do some references and say some things. First, I want to talk a little bit about my background in this topic and why I'm telling you this information, why I chose this topic. So I'm currently completing my field experience at Doug's House right now as a DSW social worker intern. So Doug's House is a hospice and recuperative care facility for people with HIV. And our overarching governing organization is called Project Transition. So Project Transitions provides affordable housing for people with HIV. And something really unique about both Doug's House and Project Transitions is that it's the only organization out there in the state of Texas. So now I'm going to be giving y'all some background about what HIV is. So HIV, or human immunodeficiency virus, is passed through contact of bodily fluids. HIV operates by attacking and weakening the immune system. The immune system is what protects us from being sick. So without proper medication, over time the virus will keep multiplying and the patient will get sicker and sicker. So recent medical advancements in the last 20 years have led to the creation of something called antiretroviral therapies, which I'm going to be calling ARTs. So what antiretroviral therapies do is stop the virus from further replicating and further harming the immune system. And so before I go to that last bullet, a few terms. So what is medication adherence? Medication adherence refers to when a patient, in this case a patient with HIV, takes their medication exactly as prescribed by their doctor. So at their correct time of day, they're taking it regularly over time. And then the viral load is referring to the amount of HIV that's in someone's bloodstream, which can be done in lab tests. So when HIV medication adherence is practiced, someone's viral load will decrease. And then when it reaches a level that's undetectable, it can't transmit the virus to another person. So that's going to be important for later on in the study. So why does medication adherence matter so much for patients with HIV? So HIV is a unique virus in that giving off of an ART without the doctor's oversight can lead to that patient developing a resistance to the medications. So what resistance means is basically that your HIV will become unresponsive to the medication that you weren't adhering to. So there are only so many ARTs on the market, just because it's such a new field of medicine. So the result of less medication adherence means less options for quality, long-term, lifelong care. So that's why I'm studying this, that's why I think it's important. But you might be thinking, why would someone not take a life-saving medication if it's available in the market? And there are actually a lot of reasons, and that's exactly what I'm going to be going into today, and that's what my study is all about. So first I wanted to talk a little bit about some of the gaps that exist right now in the literature and why there is such a need for HIV-specific research in this talk. So there is currently little HIV-specific medication adherence studies, and those that do exist are often behind paywalls, and they're not accessible to the general public. So because of this, medical professionals often refer to things like diabetes or blood pressure medication adherence studies, which is a disservice for our clients, I think, because HIV is such a unique virus. And HIV comes with so many specific social implications and barriers that I think it deserves to be studied alone. So some of those barriers include increased rates of drug use and addiction, shame, a historic lack of respect for medical care, as well as a cultural mistrust for doctors and social workers based on history. So the purpose of my study is to find a way to provide or find strategies to provide lifelong, manageable, and quality care for clients with HIV. So I wanted to find out what's not working and then where can we improve. So my hypothesis was that factors like housing instability or homelessness, drug addiction, lack of quality health insurance, and other financial barriers, and feelings of shame induced by homophobia and the war on drugs contribute to low plant medication adherence for people with HIV. Alright, so now we're going to get into part 2 where I'm going to talk about the methods of the study that I performed. So the study was supervised by Dr. McCormick, and the research collection consisted of 10 different qualitative interviews. So there were 2 participation requirements for everyone who participated in the study, which were that they had to be over 18 years of age, and they also had to have been diagnosed with HIV for at least a year. And all of these interviews were collected in February to March of 2023, and based on the Honors Department. All of the participants were compensated $20 for their time and for their expertise with personal experience. So the study was advertised in the Project Transition Housing Complex lobby. And the study was approved by faculty at SU. So I'm going to talk a little bit now about the format of the study. So all of the interviews individually range from about 10 to 30 minutes. And it kind of all depended on how much the individual wanted to talk and how thoroughly they wanted to answer the questions, since they were qualitative. So participants before the study began were informed of their rights to skip questions at any time or stop the interview in and of itself at any time. And then participants also were informed that their answers were going to be kept confidential, but also not impact the relationship with project transitions or Doug's House or any of the employees. So all of the interviews consisted of 6 demographic questions, followed by 10 interview-style open questions. So now I'm going to tell you a little bit about the demographics of the participants in the study. So as I said, I asked 6 demographic questions, which are in green at the bottom. So the collective demographics included gender, age, LGBTQ+ identity, race, highest level of education, as well as the year of their HIV diagnosis. And so I collected these demographic pieces of information in order to find themes and discrepancies across different identities of the participants. So half of the participants of the study were women, and the other half were men, which was a very nice kind of balanced study. And 50% of participants identified as LGBTQ. And the ages of the participants were from 25 to 70. So there are a few limitations in this research based on the demographics. So no one under 25 ended up participating in the study, which is a limitation. There were also no openly transgender participants in the study. So I think that's a recommendation for future research, and then also a limitation. And then as for race, 30% of the participants were Hispanic or Latino. 60% were Black and 10% were white. And again, another limitation is that none of the individuals who volunteered for participation were Asian or Native American. So now, I'm going to be going into part 3, which are the results of my study. So first I'm going to talk about the kind of big theme here, which is the barriers to care. So I did a thematic analysis of all 10 of the interviews, and I showed many different barriers to care, but these are the biggest barriers that I noticed kind of across the population. So several of the barriers to care included money and financial barriers. So the biggest of those being a lack of money for co-pays, for the medication itself, and then also for doctor's visits. And then another big financial barrier was the transportation to the clinics and to the pharmacies to go to their doctor's appointments and to get the medication. And so you might be thinking, what about taking the bus? Not only does the bus cost money, of course, but in an advanced case of HIV or a person who has HIV who is in an aging population, neuropathy is very common, which is nerve pain that can stretch your legs. So for a lot of the clients that I've worked with and for a lot of the people that they talk to, even walking to the bus stop can be excruciatingly painful. So there's that big limit of transportation. And so several people that I talked to who have been homeless in the past mentioned that their medication was stolen from them when they were living on the streets, so that was another barrier. And another reason why housing is such an important solution for this lack of medication adherence, so that people have a safe place to take, store, and keep all of their medications. And several participants, I'd say about 3, also mentioned untreated mental health diagnoses such as psychosis or schizophrenia as reasons why they weren't on their medication for periods of time. And then the biggest of all of these, besides the financial barriers that I noticed, were feelings of shame. One of the clients that one of the participants that I talked to mentioned that taking medication is a constant reminder that I'll always be sick. So as you can see, there's a lot of shame kind of within this population based on the history of how HIV/AIDS has been treated in this country. And for clinicians, one way to combat this is to work with your clients who have HIV to address and externalize the shame as it is theirs to carry. So yeah, aside from barriers to care, I also looked at protective factors. So something that I noticed a lot of participants were saying in terms of achieving medication adherence included a connection to family and community. So one of the participants I talked to said, I take my meds because I want to be my granddaughter. Another big part of achieving medication adherence is also having HIV education from a non-judgmental source, as well as previous near-death experiences that occurred for individuals when they were non-medicated. So past hospital stays after not taking meds for a prolonged period of time. A few people did mention that as reasons why they take the nap. And then another big reason is staying undetectable. So like I talked about earlier, when someone with HIV has a undetectable viral load, they can't transmit the virus to another person. So like I said up above, connection to the loved ones and the community is a protective factor. Then staying undetectable and having the education about HIV from a non-judgmental source, telling you that when you're undetectable, you also can't transmit it to anyone else, is a big protective factor. And it kind of shows how all of these different things are working together to kind of come to that goal. And then, this is kind of a summary of everything that I've learned for recommendations for the literature and then recommendations for social workers and doctors. So, for social workers, when we work with people who have HIV, it's important that we use trauma-informed care through a strengths-based perspective due to complex trauma histories of many clients who have HIV based on demographics and prejudice for being in certain groups. Another thing that social workers can do, one of the participants that I was talking to mentioned that she felt really connected to her first social worker when she first had HIV because she would come to wherever she was staying. So this participant was homeless at the time and couldn't get the transport, didn't have a phone, and couldn't go into the office to see her caseworker found out where she was staying and came to her. And she said that was a really important reason why she stayed medication at that time. Also, practicing cultural humility is very important for social workers in understanding marginalized groups' historic mistrust of certain systems, and then also providing a higher continuity of care. So a lot of people are seeing social workers here only stay on for 6 months, and then it's a new cycle of social workers. And so some of that is kind of on that more macro side of practice, on the organizations themselves, to take care of their social workers and really to make sure that they're being compensated fairly and working in an environment where all of the caseworkers and all of the employees feel safe. And then I also asked some questions about what doctors can do for their patients to make them more medication dependent. And so again, kind of going off of what we talked about with social work, doctors can allow home visits, and that really impacts clients getting access to this care. So kind of making up for that transportation barrier that we talked about earlier can make a really big difference. And then another thing is making an effort to ensure confidentiality among all of your patients. A lot of people, when I ask them to describe their HIV doctor, said like loud or like kind of saying my business, whether it's to other nurses or other doctors. So making sure that we're treating our clients with the most confidentiality, especially for clients with HIV, is really important. Where a lot of the time, because of all of that shame, they won't seek care in the first place, and then they go out of care and get sicker. And then the last thing that I really was noticing when I was talking to people is, aside from treating experts or treating clients as experts in their own care and empowering them, making an effort to understand why clients are on medication adherent is really important. Instead of just getting frustrated or shaming the clients, a lot of participants in the study said, my doctor gets really upset and my doctor isn't very patient with me when I tell them that I'm off my meds. All that's going to do is further create shame for their distance, the client or the patient from their provider. And then the last thing that I wanted to kind of end off with is that one of the participants said, talk to me like someone you love, in response to my question about what doctors can do to support you in reaching medication adherence. So kind of removing a little bit of that kind of like, not necessarily professionalism, but changing how we make professionalism, just really showing up as a human for clients and for patients. This would work. So yeah. I wanted to give a few thank yous as I continue with my research. So I wanted to thank Dr. McCormick, of course, for the support for always showing up and being another social worker. And I also wanted to thank all of the staff at Project Transitions, specifically Miranda Salazar, who's my supervisor, for all of the support. I also wanted to thank fellow internists, Sandra Camarillo, for helping me with the interviews, and Dr. Capron for all of your support in the field. The honors program for funding this opportunity in this study, and also my dad, and I learned very much. So, yeah, these are my references. And that's
questions about the thesis?
Well, first, excellent presentation, and all underneath that, like, just excellent. My question is, while it's really beneficial to us to hear about your research findings, I'm curious if you have plans to help me disseminate these findings beyond sort of an academic environment, and why might you do that, what that means to you?
Yeah, so one of my plans that I have with my supervisor is also to show this research to the board, and hopefully through that allow board members to make changes in the organization that can allow social workers to better show up for their clients, making changes in funding. Because I mean, again, specifically kind of thinking about that lack of social worker retention and caseworker retention, kind of showing people how the macro influences can kind of impact those more like micro roles. So showing it to the board, and then also just like incorporating it into conversations that I have with other like
if you've noticed any of these things being addressed in their work.
I think that definitely something that I have noticed being addressed is those financial barriers. So getting people bus passes, getting people access to different forms of transportation. And then at Doug's House, we also have an accompany program. So we offer to accompany all of our clients to go with them, and that helps with advocacy, but also just kind of like making sure that they're safe, making sure that they have the support that they need. A lot of times, the people who are staying at Doug's House don't have a lot of connections and don't have a lot of people willing to go with them to the doctor. And so just kind of offering that support, and then also that financial barrier has been really big in improving client medication adherence over time. And then another thing that I would say we do is at Doug's House specifically, just really asking people, like setting timers for everyone's medication, like as simple as something like that, and just reminding people when it's time, making sure we keep on a calendar, like when clients are going to need refills on the medication, so we can check in with them and kind of allow them space to advocate for themselves, and just let them know, like, this is coming up, you have a plan, but not getting too involved to the point where they're not really learning about health literacy. But yeah, I would say those are the two biggest areas that have been addressed, and I hope in future conversations that I have with the board there, that there can be more space to improve, especially on a macro level. Any questions?
Are you staying on at Doug's House after graduation, or what's coming up next for you in your social work career?
Yeah, so I'm going to stand as a PRN caregiver there, and then I'm also going to grad school at UT.
With that, I'd love to invite up Dr. McCormick, your advisor, to say a few words.
Yeah, that was amazing. Carol, as we would all expect. So I met Carol her junior year. She came to social work a little bit late, and somehow we met each other, and we had 3 classes together, back to back, one right after the other, 3 in a row. And I told her, if you can survive this, there is absolutely nothing that this profession, this world of social work can throw at you that you can't handle. And she totally slayed. She did great. But Carol, I know I can speak for Dr. Heffron and Dr. Heffron and Dr. Beck in saying that you were just so brilliant and so kind and fierce in all of the things that make an incredible social worker and an incredible person. We are all so proud to know you, so privileged to be a part of your journey, and unbelievably excited to follow the amazing things that you are going to do for populations on the margins and social justice and trauma and everything else. So we're so proud of you. Congratulations.
Cord and Stoll to recognize Carol's accomplishments today, but also in her 4 years